Hi, this is Dr. Akhtaramini. Today's topic is peripheral corneal ulceration or peripheral corneal thinning. Peripheral corneal ulceration thinning, also known as peripheral ulcerative keratitis. When inflammatory, it refers to presentation characterized by thinning and ulceration, preferentially affecting the peripheral rather than central cornea, and spreading around the margin. It should be noted that any cause of corneal ulcer can affect the periphery. It includes marginal keratitis, this is discussed already, Mooren ulcer, Tyrian marginal degeneration, and Dellen. Dellen is a localized corneal disturbance associated with drying of a focal area. Here you can see Dellen. It is a localized corneal disturbance. It is usually associated with adjacent elevated lesion, for example pinguicula or large subconjunctival hemorrhage, that impairs physiological lubrication. Generally mild, though can occasionally be severe, including dysmetocele formation and corneal perforation. Other peripheral corneal ulcer associated with systemic autoimmune disease. Other causes include ocular rosacea, which we have discussed, furrow degeneration, which is shown in this picture, mild peripheral thinning in the elderly, usually benign, and other causes pellucid marginal degeneration. The first peripheral corneal ulcer is Mooren ulcer. It is a rare autoimmune disease characterized by progressive circumferential peripheral stromal ulceration with later central spread. There are two forms. The first affects mainly older patients, often in only one eye, and usually responds well to medical therapy. The second is more aggressive, likely to need systemic immunosuppression, carries a poor prognosis, may be bilateral, associated with severe pain, and tend to occur in younger patients, including widespread reports in men from the Indian subcontinent. In at least some usually milder cases, there is precipitating corneal insult such as surgery or infection. Associated systemic autoimmune disease and corneal infection should always be ruled out. So, the Mooren ulcer, it is an autoimmune disease. Diagnosis. There is pain which is prominent and may be severe. So in Mooren ulcer there is severe pain, there is photophobia and also blurred vision. Signs: there is peripheral ulcer involving superficial 1/3 of the stroma with variable epithelial loss. Severe distinct foci may be present and subsequently which coalesce. So this is peripheral ulcer. This is local peripheral ulceration. There is undermined and infiltrated central edge. Here you can see undermined and infiltrated central edge. This is the characteristic, undermined and infiltrated central edge. Limbitis may be present, but not scleritis. This aids and distinguishes from systemic disease associated PUK. There is progressive circumferential and central stromal thinning. Here you can see progressive circumferential central stromal thinning, an advanced disease. There is vascularization involving the bed of the ulcer up to its leading edge, but not beyond. The healing stage is characterized by thinning, vascularization, and scarring. This is a healed stage in which there is thinning, vascularization, and scarring. Iritis is not uncommon. Complications include severe astigmatism, perforation following minor trauma. Spontaneous perforation is rare. Secondary bacterial infection, cataract, and glaucoma. Treatment: topical steroids as frequently as hourly are combined with a low frequency prophylactic topical antibiotic. If an effective response is seen, treatment is tapered over several months. Topical cyclosporine up to 2% may be effective, but can take weeks to exert a significant effect. Tacrolimus 0.1% ointment is effective in controlling refractory cases. Artificial tears and collagenase inhibitors such as acetylcysteine 10 to 20% are the adjunctive topical therapy. Conjunctival resection may be combined with excision of necrotic tissue. Is performed if there is no response to topical steroids. The excised area should extend 4 mm back from the limbus, 2 mm beyond the circumferential margin. Keratoepithelioplasty. It is the suturing of a donor corneal lenticule onto the scleral bed. It may be combined to produce a physical barrier against conjunctival regrowth and further melting. Steroids are continued post-operatively. Systemic immunosuppression may be needed, including steroids for rapid effect should be instituted early for bilateral disease, or if involvement is advanced at first examination, biological blockers show some promise. Systemic collagenase inhibitors such as doxycycline may be beneficial. Lamellar keratectomy involves dissection of the residual central eyelid in advanced disease, may remove the stimulus for further inflammation. Perforation management is as discussed earlier in this chapter. Visual rehabilitation, keratoplasty with immunosuppressive cover may be considered once inflammation has settled.